Education Committee. Thank you so much for joining us. If you're not familiar with NASHIA, we are a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. Before we begin, I have just a few housekeeping details. A GoToWebinar user guide is available for download from the NASHIA website. This is a great resource for making the most of your webinar experience. An online GoToWebinar help button should also be visible at the top of your attendee control panel. For technical assistance, you may also call either of the numbers listed here on this slide. To control for background noise, all attendees' microphones will be muted during the presentation. However, you may submit questions for the presenters at any time by typing and submitting them in the question text box on your GoToWebinar toolbar. Any questions that are not answered during today's webinar will be answered later via email. There are additional materials available for download from the NASHIA website at the link listed on this slide. You may find these resources very useful during the presentation. And now it's my pleasure to introduce our speakers, Dr. John Corrigan, and I'll be filling in today for Susan Vaughn, who is not able to attend the presentation today. Dr. Corrigan is a professor in the Department of PM&R at Ohio State University and director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. He is a principal investigator for the Ohio Regional Traumatic Brain Injury Model Systems. Dr. Corrigan chairs the executive committee of the TBI Model Systems project directors. He's editor-in-chief of the Journal of Head Trauma Rehabilitation, and he has received local and national awards for his service and research in the field, including the Brain Injury Association of America's William Fields Cavness Award and the 2007 Robert L. Moody Prize. I'm pleased to introduce you to Dr. John Corrigan.
Thank you so much, Carrie. Before we get started, I just want to make sure everyone has seen my first slide on the screen there and not my to-do list for today or email or something else. Are we all set to go on the visuals?
It's okay to me. Mm-hmm.
All right, great. Well, I will jump right into this. I'm very pleased to have the opportunity to present what I think is critical information about traumatic brain injury and specifically what I hope to cover, although quickly today, are these questions. The definition of TBI, how we judge its severity, how often does it occur, what are the long-term effects, what treatment populations are more likely to include people with TBI, and why is TBI different than other ways the brain is injured. So we'll launch right into it. The Centers for Disease Control and Prevention's definition of traumatic brain injury is this. It starts with that it's an insult to the brain. And there the confusion begins because the key is that the brain is injured, not the skull or the skin on the outside or the scalp or the face. But the key is that it's an insult to the brain. And as we'll see in a moment, we basically know that by anoxia, but traumatic brain injury is caused because there's energy exchange from the outside with the brain. And the importance of that we'll cover today. We know that the brain has been affected because an altered state of consciousness occurs. There's some change in the functioning of the brain, and we'll talk a little bit more about that as well. And finally, traumatic brain injury can be either temporary or permanent. Thank God that not all blows to the head that affect the brain result in permanent effects. Unfortunately, however, we are not sure exactly where the line is between temporary and permanent. And is that a characteristic of the injury? Is it a characteristic of the person? Both I'm pretty sure it's one or the other or both and not neither. But that is probably one of the biggest questions in research on traumatic brain injury right now, is what makes some injuries become permanent. And of course, the more severe ones we know that generally happens, but what about some of the less severe or concussions? So we have multiple ways in which we, over the years, have talked about the severity of traumatic brain injury. This is just a few. The Glasgow Coma Scale score was used in neurosurgery for a long time, and it is still used. Length of loss of consciousness, how long you're knocked out, is very useful, and I'm going to speak some more about that. Length of post-traumatic amnesia, for what is the first thing you remember after the injury. When collected prospectively, meaning it's being checked for regularly as the person's consciousness. Thankfully, the distribution of injuries is more like this, that we have predominantly mild injuries and a much smaller number of moderate and severe. And we'll be looking at actually some estimates of incidence and prevalence in a moment. I'm going to focus for a minute just on length of loss of consciousness, because in many ways I think it's the most available way of categorizing severity that we have. And what I want to show you here is just kind of a continuum of TBI severity, from the least severe on the left to the most severe on the right. And we talk about mild TBI or concussions, and I use concussion. I consider concussion to be just a mild traumatic brain injury. As it gets more severe, we talk about moderate TBI and severe TBI. The way that loss of consciousness maps to that is that showing signs that you've been hit in the head, that the brain's been affected, being dazed, confused, or having a gap in your memory, but not actually knocked out, is within the spectrum of mild TBI. Actually losing consciousness then ranges from mild TBI to severe TBI. So just knowing whether somebody had lost consciousness without knowing for how long, as we'll see in a moment, doesn't tell you all you need to know. When there's very severe effect on the brain, then of course we get coma. But the point of this graphic is to show you just a couple of major milestones. And that the first one is when there's any loss of consciousness. And some of the research that's emerging is suggesting this is not a bad place to say odds of some residual, whether, if not permanent, effects can occur if there's loss of consciousness. Second, and more certain in terms of that inference, is if that loss of consciousness goes on for 30 minutes or longer. And that's the demarcation between a mild and a moderate traumatic brain injury when we're using loss of consciousness as the scale. And once we get into moderate or the more severe traumatic brain injuries, which can include more than 24 hours loss of consciousness, the likelihood of some kind of residual effects, even if it's not disability, are quite high. So that's just a quick thumbnail on severity, and something to, when you're speaking with folks, often loss of consciousness is something that you can determine from the conversation, and may be helpful in understanding the severity of the injury involved. This is from CDC. This is looking at switching gears now into epidemiology. Who gets injured. This is age of persons injured along the bottom, and then the what rate per 100,000 is graphed there. And the solid line is emergency department visits, and you can see they're very high for the youngest children, and reducing some little blip up there in adolescents, and then dropping until you get into our older years, into 65 and older, when emergency department visits pops back up. Hospitalizations, as you can see, popped back up at that time as well. And we will be talking a little bit later about the tremendous growth or increase in hospitalizations of older adults. Death kind of follows roughly, and particularly with increased deaths in the later years. In adolescence and early 20s, when people are just starting to drive, there's also a blip in hospitalizations. This makeup of the population of persons with TBI has actually changed rather dramatically in the last 15 years, as we'll be talking about some more. CDC talks about their incidence triangle, and these are based on the most recent estimates, the number of deaths, hospitalizations, and emergency department visits nationally. Critical here, however, is the dotted base of the triangle, and that's those who don't receive medical care, at least this kind of medical care, and thus are outside of these incidence counts. And particularly as we become more aware of concussions in sports, et cetera, if you think about a child seeing the athletic trainer or seeing the physician on the sideline, or the next day the physician at the school, a physician as part of the athletic program, or their own pediatrician in their outpatient office, none of those kinds of visits would be counted in the main part of the triangle. All those would be in that base. And we don't know quite how big that base is, and that's a goal that deficit that the CDC is trying to address. And that arrow is meant to direct your attention to that part. We have some recent data published and some unpublished data about prevalence of traumatic brain injury. So what we just saw was how many occur in a year, but this is how many people in the population may have had different histories, of lifetime histories of traumatic brain injury. And this is relatively new information. We so far only have it for a few geographic areas, Colorado, Ohio, and the province of Ontario. But it starts to paint a picture that's, I think, a different picture than when you look at annual surveillance. So those who've had at least one traumatic brain injury with loss of consciousness in their life, maybe as much as a quarter in Colorado, or as low as 17% in Ontario. That asterisk there means that they used a slightly different definition. They were only interested in loss of consciousness that was for 5 minutes or longer, or resulted in a hospitalization. I think more interesting is the moderate or severe traumatic brain injuries. As many as 6% we found in the population-based survey in Colorado, Ohio, to 2.7%. I should say that both of these are based on random digit dialing of the adult non-institutional populations, civilian populations in those states. A phenomenon that we'll talk about a bit more that I'm interested in is childhood injuries, and a consistent finding that in both Colorado and Ohio we had just under 7% of individuals who reported at least one loss of consciousness, TBI with loss of consciousness, before they were 15. Actually, I should say before age 16, so up through age 15. And an indicator that we use for looking at whether a history is problematic or not is either that you have the childhood injury with loss of consciousness or have had a moderate or severe TBI any time in your life. You can see that in those two states it's hovering around 10%. So a 10% prevalence rate, if we're counting it right and using the right criteria, is considerably higher than anything we have talked about before. Of course, that doesn't have to mean that's with disability, but I think we use these criteria to mean that there is at least some residual effect for the person. I sometimes compare then these estimates. You can see the top two rows of this slide are the Colorado data we just looked at, the Ohio data, which is still in analysis, and that's why I don't have any TBI yet. We haven't weighted that yet. But you see the results for those two states. But below that are some populations where we have, better or worse information about possible prevalence rates in terms of lifetime history. For OEF-OIF veterans, looking at the post-deployment or post-combat figures are really quite a bit higher than the general population. I should mention that the reason the moderate and severe is no different from pre to post is that this was done on service members who would not have been, if they'd gone into the polytrauma system because of a more severe injury, they wouldn't have been counted here. Based on some work looking at prisoners, we're estimating 60% any TBI, 14% moderate severe. You can look at some of the others, those in substance abuse treatment, psychiatric inpatients. That's based on one study and should be taken with a grain of salt. Several studies of reported homelessness, which we're going to look a little more at. But the point of this slide is to say, if you look at the population rates up above and then problematic subpopulations for whom there are problems of living in society, you can see that often the rates are double and sometimes even more. If you just take moderate severe, if it's 3 to 6%, let's say 5% in the general population. Well, among prisoners, it's 14%, and persons in psychiatric inpatients, 20 maybe, the homeless 12. So the point of this is to say that we see a much higher prevalence in terms of history of traumatic brain injury in populations that generally require more supports to function successfully. So let me just go into a little more detail about some of those populations and essentially address the question, to what extent is TBI associated with behavioral problems, such as what we see in psychiatric disorders, substance misuse, aging, and disability. And unfortunately, because of time, I'm just going to show you a couple studies, and then I'll try to summarize kind of where the literature is. But the studies don't cover everything that I'll summarize. I think a real important study by Holsinger in 2002 looked at World War II vets, and they're able to create a very good comparison group. Those who had a closed head injury and definitely traumatic brain injury affected their brain versus other service members who were injured but didn't have a traumatic brain injury, followed up with them 50 years later and assessed them for the presence of depression. And they had, those who had the traumatic brain injury in service, in combat, had a 50% greater likelihood of lifetime depression and a 60% greater likelihood of currently experiencing major depression. That was after 50 years. And the more severe the TBI while they were in service, or they're being older now, both were associated with a greater likelihood of depression. Jesse Fan and colleagues looked at insurance data from the Northwest area, and they isolated individuals who had a traumatic brain injury and had no prior psychiatric disorder, and then looked to see what developed after, and they compared them with folks who did have a prior history of psychiatric disorder. And one of the things they found I thought was interesting was that that there was an increased likelihood with moderate severe injury, notice that, moderate severe injury, of psychosis 6 months to 2 years post-injury for the group who had no prior psychiatric disorder. So it was kind of on a delayed onset. It wasn't there immediately, but it developed over time. And notice that it was for psychosis. We've always known that there's a lot more anxiety and depression after traumatic brain injury, but there's this emerging data, this study and some others, suggesting there's also greater likelihood of psychosis, and it often develops later term. If an individual had before their injury, had a history of psychiatric disorder, and then had a moderate severe injury, their first 6 months, they had increased psychiatric problems, but they didn't, so it's kind of like it exacerbated their existing, but we didn't see this delayed phenomenon of onset of psychosis. For mild injuries, there was no change in the likelihood with or without pre-injury psychiatric disorder. So interesting and important study, I think, in terms of understanding some of the differences that might go into the manifestation of psychiatric disorder. Gabriella Ely in Ontario, in a survey of adolescents, this is a population-based survey, looked at correlates of those adolescents who had a history of TBI already, and her definition of that was greater 5 minutes or greater loss of consciousness or an overnight hospital stay as a result of the injury. And you see the odds ratios there, which are adjusted for grade, sex, and how they were sampled. It shows that there's double to triple likelihood of things like suicidal ideation, suicidal attempt, being on a prescription for anxiety and depression, and I think honestly beating up or hurting somebody on purpose. So in this adolescent population, we already see some greater manifestation of psychiatric issues with a history of TBI. So the summary is that depression is definitely more frequent, and depressed clients who've had TBI are more likely suicidal, more successful at least. There are higher rates of anxiety disorders of all sorts, including PTSD, which is being looked at quite a bit more recently since our wars in Iraq and Afghanistan and the experience of our returning service members. And it does appear, by the way, clear that having a traumatic brain injury while deployed does increase the likelihood of PTSD. There are higher rates of psychosis now that we're seeing. That's a more recent finding. And higher rates of personality disorders, access to disorders for persons with traumatic brain injury. And something we'll come back to is that a childhood TBI doubles the likelihood of psychiatric disorder by early adulthood. We'll look at the source of that. So that was psychiatric disorders except substance abuse. This slide is showing a series of studies we've done in Ohio where we've gone into different substance abuse treatment settings and screened for traumatic brain injury. In adolescent residential treatment, about 1 in 4 had a prior history of TBI with loss of consciousness. Perhaps as adolescents had not had the same opportunity yet to experience traumatic brain injury. But in adults who are in higher levels of care, as in residential or intensive outpatient, or adult prisoners who are in therapeutic community, meaning substance abuse treatment in a therapeutic community approach within the prison, they are about half had at least one TBI with loss of consciousness. Something that we noticed was that in the prison population, those receiving substance abuse treatment tended to have histories of more severe traumatic brain injury, a higher rate of moderate and severes. This is one small dual diagnosis treatment, meaning dually diagnosed with a substance use disorder and severe mental illness. Actually, we weren't involved in the screening of that, but they found 72% of the participants had a prior history with loss of consciousness. There is a study coming out soon of a larger sample in Washington, D.C. that found 80% had a prior history of TBI with loss of consciousness. This is from Wayne Gordon's group when they looked at treatment facilities, 27 of them around New York State. And compare, after screening, compare those with a history versus no history of TBI. And this is pretty consistent, we see in other studies, that your age at first use is lower with a history of TBI, and age at first use in substance abuse treatment is sometimes an important indicator of the likely severity of the later substance use problem. tended to have more treatments. And in general, as we'll see in a moment, what we see is that there's just a worse manifestation of the substance abuse. And then a theme that we see many places is that many of these folks have the trifecta, as we sometimes say, where they have the substance use disorder, they have other psychiatric illness, and they have a traumatic brain injury as well. As you can see here, it's about anywhere from a 50 to 100% increase in the likelihood of either having a current diagnosed mental illness or having a prior hospitalization. This was real evident in work that Robert Walker did in the state of Kentucky, where every individual entering substance abuse treatment, the public substance abuse treatment programs in the state were screened for traumatic brain injury, some almost 8,000. And what you see here is based on the history of having no prior TBI, one TBI with loss of consciousness, or more than one TBI with loss of consciousness, the likelihood of different psychiatric comorbidity. And so again, reinforcing that in a substance abuse treatment population, not only do you, when you have the TBI, you're quite likely to have other psychiatric disorder or morbidity as well. Jerry Mishu and I summarized the substance abuse treatment data about TBI in persons receiving substance abuse treatment, concluded there's evidence that they're more likely to abuse at a younger age, have more severe substance use disorder, more co-occurring mental health problems, and have poorer prognosis for successful treatment outcomes. That's something that takes a whole nother webinar to talk about why that occurs. For prison, now we're talking about prisoners, and I love this slide because it's colorful, but it is actually not the best data. This shows from multiple studies those that have the rates of TBI or TBI with loss of consciousness, and I pretty quickly suggest some consistency. But the best data to look at is actually from a meta-analysis that was done by Eric Sharoma and Pam Ferguson and Elizabeth Fickelsheimer at Medical University of South Carolina, where they collected studies of where there have been screening in multiple kinds of offender types, whether it's jails, prisons, state prisons, federal prisons, and then it was weighted by both gender and offender type. And the overall prevalence of prior history they suggest is about 2/3. If you do a more in-depth interview, you're going to find almost 2/3 have had any TBI. This is prisoners of all sorts, and TBI with loss of consciousness a little more than half. So compared to the previous slide, the any TBI is a little bit lower, but the TBI with loss of consciousness is a little bit higher. In the homeless now, 4 studies I'm aware of, all pretty consistent in finding what in those populations, what proportions have prior histories of traumatic brain injury. From the work done in Toronto, that to see increased likelihood of problems with mental health and substance abuse, seizures, mental health and substance abuse, when the worst injury that they've experienced is moderate or severe. Particularly, that's true of seizures and mental health problems. So the worst injury has worst comorbidity. And then these data come from a little different angle, but we're looking at just in aging and disability populations. For instance, if you're working in your home and community-based services, what might you expect? There are several relationships between history of TBI. Earlier TBI is related to later life issues, so we'll see a little bit more. There is a substantial proportion of folks with more severe TBI who initially do well, but are declining in function as time goes on. We're going to look at some data on that. And then the thing that I think we tend to overlook very, very frequently is that when we think about disability due to TBI or TBI in a disability population, we think about those folks whose disability is due to a TBI that the system or the individual is aware of. But people with other in there for other primary disabilities can also have histories of TBI. We're going to look at that a little bit more. So in terms of the current aging literature, we know that a history of TBI increases the likelihood of certain degenerative diseases, Parkinson's, we're pretty sure of, Alzheimer's, mixed, but yes, and then chronic traumatic encephalopathy is pretty much by definition. It means an earlier traumatic injury to the brain has caused a neurodegenerative disease. The mechanism, though, for this relationship is not well understood. The association with Alzheimer's disease is the strongest if you have either a more recent traumatic brain injury or you have the APOE4 positive allele. For the more recent TBIs, you have to allow that it's possible that the TBI, let's say, due to a fall, might be prodromal. It might be kind of the first clinical effect of decline, and while the Alzheimer's or even the MCI diagnosis comes later, it's not really cause and effect. This is because the fall was created by some of the same degenerative process. However, that said, there's a couple recent surveys suggesting much earlier in life TBIs are associated with a greater likelihood of dementia later in life. That's clear with death. The dementia as I said, has been a little more equivocal. What, though, is more clear is that an early life TBI makes you more vulnerable to a later fall. So maybe that's the mechanism of the relationship. As you can tell, we haven't worked out kind of all the arrows for causality when we're looking at the relationship between problems in aging, dementia in particular, and TBI. So moving on to my second point from before, this graph shows you the proportion of the U.S. population. This is from the first decade of this century. The proportion of the U.S. population in different age groups. Those are ages along the bottom, so starting with age 16 to 19, and then in tenure decrement segments up to 100 and over. So this is the general population of the U.S. When you look at the in the U.S. for a primary diagnosis of traumatic brain injury, this is the proportion. A few years back, we were really quite surprised to see this big bump in the older age groups. My first suspicion, because I'm a suspicious person, was that this was related to some kind of upcoding or advantage in coding being done in rehab facilities, and where older adults with other things were being also coded with a traumatic brain injury. However, and I need to apologize to my colleagues who are rehab administrators, when we compared acute care admissions in the U.S. again for traumatic brain injury, it was much closer to the age makeup that we're seeing in rehab than it was to the general population. As a matter of fact, when we use an algorithm for removing the mild TBIs from the acute care admissions, it almost perfectly matched what we're seeing in rehab. It's turned out that this is a phenomenon that is being seen in most Western countries. In Europe, we're seeing it. Colleagues in Australia are seeing it. That particularly in the first decade of the century, there was a tremendous increase in the number of persons 65 and older receiving rehabilitation for a primary diagnosis of traumatic brain injury. And it wasn't just in rehab, we're also seeing it in acute care. So this again is this is just rehab for TBI, primary diagnosis of TBI, anyone older than 16 or older in the US. And what you can see, the darker shaded bar at the bottom is those who are under 65. and the lighter shade on top is those 65 and older. And that, as you can see, by 2009, it had shifted to where more than half of those being admitted in the U.S. for rehab for TBI were over the age of 65. Again, this has been seen in other countries and what some have called the silver tsunami. This is not the baby boom. This is actually the great generation, the parents of the baby boom for the most part. The baby boomers are only starting to slide into that 65 and older group. They just poke their nose in the very front end of it. This is pre-baby boom. And so you might want to imagine what these numbers look like post-baby boom. The point of this is if you're looking at aging and disability populations, those having more severe traumatic brain injuries have shifted in age dramatically. So a third then point about thinking about when we're working with a person within the aging disability areas is that there is a group that have more severe injuries, are doing better initially, and they're not so well after. And to make this point, I'll share with you some work that TBI Model Systems did in conjunction with the Centers for Disease Control and Prevention, where we were able to take about 6 years of data and weight it to the U.S. population to come up with population estimates for those who had rehab for a primary diagnosis of TBI, who were 16 years of age or older. And what we wanted to look at was, well, so what are the outcomes at 5 years? And thankfully, for looking at that, we had our weighted data suggested that we had known outcomes for 84.4% of the sample we were working with. That was the good news. The bad news was that for 1 in 4, the known outcome was that they had deceased. So these are all individuals who had survived their injury, went to rehab, were alive when they left rehab, but now when we follow up 5 years later, they had deceased. And this is what it looks like by the age they were at injury. So along the bottom, along the bottom is the age at injury. 21 to almost 22% were dead within 5 years. And while you might think, well, look at the number of older adults who have died in that time, don't older adults die? The only age group that was not, well, every other age group except the 80-plus group had excess mortality, meaning they were more likely to die than their same age, gender, and race-matched peers. In the 80-plus group, it is about the same mortality rate. This wasn't based on this study, but another one that we did. It's excess mortality all the way up to, actually, it was age 85 is what we found. We still wanted to know the outcomes at 5 years, but after someone has deceased, there's now a lot of other things to know. So we went back and we took those who were still alive, and we weighted the data again so that we could come up with U.S. population estimates. And this is just a few slides from that. One of the things we found is that about 12% of those still alive are institutionalized, and this means living anywhere except in a private residence. That residence may not be their own, or they may be supervised in it, but this is all kinds of institutionalization. Much higher in the older age groups, as you might imagine, maybe more likely to be in nursing facilities. But even starting around age 50, you see some 10% are in institutional settings. By the way, for these next couple slides, along the bottom is always their age at injury. That's not the age 5 years later. So anything that it's about a 2% difference, you can be absolutely sure is a significant difference. We looked at those who were rehospitalized at least once in that 5-year period, and it was 50% overall. A very slight age trend. It seemed to be happening across the ages. This did include planned rehospitalizations, which do occur, particularly for reworking any damage, surgical work on the skull, etc. We weren't able to separate out the planned from the unplanned. In terms of the extent of disability, some almost 60%, these are now again of those still alive 5 years later, had a moderate or severe disability, which means they may be able to spend some time alone, up to 3 hours or so, but not need to be supervised overnight, are not able to move about in the community without assistance, and normally would have some personal care, need some personal care assistance as well. Here again, you see some age trend, but actually those injured in their 40s had the highest rate of moderate or severe disability, and even the younger folks have pretty high rates. The 20 to 29-year-olds, half of them showed at least moderate or severe disability. This next slide is the reason that I've included these, however, and that what we looked at is, well, of wherever they were at 5 years, how was that relative to a year or two after their injury? And what we found, which was really very surprising, was that almost 40% had declined from an outcome they had achieved at either 1 or 2 years post-injury. I'm talking about how they left the hospital or how they left rehab. I'm talking about 1 or 2 years post-injury, they had declined at least, and we were using the Glasgow Outcome Scale Extended, at least one category on that scale. Um, 5 years later. And the other remarkable thing here, I think, is that it's not specific to age. Younger, middle-aged, and older all showed this tendency to decline. So if you look at the total experience, for everybody who's older than 15 and receives rehab for primary diagnosis of TBI, by 5 years after that TBI, we would expect 2 in 10 to have died, and another 3 in 10 to have deteriorated from recovery attained 1 to 2 years post-injury. So not so good outcomes for at least half of that group. This is why myself and Flora Hammond and others, this has been Brent Mazzell, many have written now on traumatic brain injury as a chronic health condition. And while we don't have time to go into more of that detail now, the reasons for the decline and the chronicity of the condition is multifaceted. It's not any one thing that any one way in which the chronicity is manifesting, or is it any one reason why this definite deterioration is occurring. Okay, so finally, I wanted to make that last point that I mentioned earlier, which is that when we look at aging and disability populations, we often tend to think about just those whose disability came from their traumatic brain injury. But using the statewide data in Colorado that we saw for the general population, we also had an indication of just who within that group, within that population, had a disability. And this was using the definition of disability used in the behavioral risk factor surveillance system. What we found is that more than half of adults with disability had a traumatic brain injury of some sort. And that if you want to be a little more specific, you could say also that it is almost 38% had at least one traumatic brain injury in their life with loss of consciousness. So that's the sum of that pink pie shape, the 27% plus the 6% and the 5% above it. Or if you want to be even more conservative, You could, and just limit it to those with at least one moderate or severe traumatic brain injury in their life, when we're pretty sure that is going to have residuals. It's some 11%. So that's about double the general population rates, and it's way above what you would estimate you would come up with by looking at diagnoses in charts or through assessment. So in the aging and disability populations, we need to be thinking about history of traumatic brain injury and not just limiting ourselves to when the traumatic brain injury caused the disability. So to recap what this section, earlier life TBI does seem to make people more vulnerable to later life falls, later life TBI more vulnerable to death and dementia. Half of those receiving rehab for TBI are older adults already, and half of those with more serious TBIs decline in the first 5 years after their injury. And that's young and old. 40% of adults with disability have had one TBI with loss of consciousness in their life. As we didn't cover specifically, but one TBI with loss of consciousness itself, doubling the risk of permanent impairments. Okay, so transitioning here, and I apologize for the rate of delivery, the speed of this, but we're trying to cram a lot of information into a little bit of time. So what is different about traumatic brain injury? And often when we're working on policy issues, the needs of persons with all kinds of acquired brain injuries may be, in terms of their psychosocial needs, there might be generally more commonalities than differences. But I believe it's always important to keep in mind what can be specifically different about a traumatic acquired brain injury that's from an external force, a traumatic brain injury, versus the other acquired brain injuries, and you'll see why in a moment here. There are three reasons why I think of early developmental TBI. So we know the fingerprint of a traumatic brain injury is that the frontal areas of the brain, including the frontal lobes and anterior tips of the temporal lobes, are the most likely to be injured, and that's regardless the point of impact to the head. Hit in the back of the head, hit on the side of the head. Yes, there'll be often contusion at the point of impact, but wherever the impact occurs, there will also be damage to the frontal areas. And that includes also when the external force is one that doesn't cause a blow, like when you're being shaken violently, shaken baby syndrome, or in blast exposures. And what's happening is that the head is being moved about, or whether it's because it has hit against something or something's hit it, or just the shaking or exposure to blast. And when that happens, and there's sufficient energy that the brain starts to move within the cranial bulb, or jiggle, I sometimes say, then we get the effects of traumatic brain injury. And thankfully, the brain sits in kind of a gelatinous be towards the front, as you can see here. And the result of jiggling or being scraped across those bony ridges is that we have a higher likelihood of injury to these frontal areas. And that's why no matter where the blow to the head comes or when shaking occurs, the frontal areas of the brain are more likely to be bruised. As is being shown here, whether it's our original old autopsy work on the right there, some of the connections, the neuronal connections. I'm going to back up a slide here. that come out of, I guess I don't have a cursor, but just to the right of that pink area you see in the drawing on the right, just to the right of there, you can see there's a lot of different structures kind of all pushed in there, and those different structures have different density and sit in different planes. And so when you shake them, they move and respond to that shaking at different speeds. And that causes any neurons that are, any connections that are moving through that material to be stretched and torn and sheared. So not only do we get more bruising, but we also get more shearing into the connections into the frontal lobes. So the result of that is that there are some specific brain behavior relationships that rely heavily on the frontal lobes. And I have said more than once that if I were going to pick a lobe of my brain to be injured, I don't think I would not want it to be the frontal lobe. And if you look at the kinds of functions that we normally associate with the frontal lobe being critical to their successful operationalization, that these are the things like initiation, problem solving, impulse control, self-monitoring. A key to many of these functions is that they are things we need to get along successfully in society. And this is, I think, the connection to the higher rates of history of traumatic brain injury that we saw in certain treatment populations in an earlier slide. Not only is it some of these higher level executive functions, but in particular, we see some more problems in self-control. And I'm going to cover that next. This is the work, sometimes it's called, people have different words for neurobehavioral contributions. There's actually a field of study called neuroeconomics that looks at the neural connections that underlie economic decisions. But the basic issue here is that behavioral problems can be seen as disorders of how we process or anticipate either a reward or a punishment arising from our behavior. And I'm going to talk about one example of that, delayed discounting. Delayed discounting is kind of similar to delayed gratification, except that it's kind of the reverse. The idea is that while delayed gratification is how long can you wait for a reward in the future, delayed discounting is how much does the value of a reward decrease as time to its delivery gets longer. So the classic example, the classic study is that if I said to you, would you prefer that I gave that 1 year from now, I give you $20, or 1 year and 1 week, I give you $22? We will do the processing. We'll generally say, 1 week for 10%, that's worth it. I'll take $22 in 1 year and 1 week. But if I change that and I say, would you prefer to get $20 right now or $22 a week from now, some 60% of people who respond will switch and take the $20 right now. This drives economists nuts. It's the same math. It's 1 week, 10%. And yet we have a tremendous bias towards the $20 when the prospect of getting it is immediate. And that immediacy is the point. And this and other kinds of studies consistently show that once an immediate reward is on the table, another system in the brain, some call it the red system, that's the lines in red portrayed here, gets involved in this basic decision about whether or not there should be, you should wait a week for a 10% gain. And in this case, what you see portrayed here in these images are areas of the brain that are critical or key spots in this network, in this red system. And it includes the medial prefrontal cortex, the ventral striatum, the medial orbital frontal cortex, all of which are areas that we just looked at a moment ago as being more vulnerable to the frontal lobe injury that occurs with traumatic brain injury. So that's the second. second source of longer-term issues I wanted to mention. So the third is the developmental contribution. And this is where we're emerging data suggesting that early TBIs, even if mild, may predispose to later behavioral problems. And in my mind, everybody born in 1977 in the Christchurch, New Zealand area who said yes was recruited into the study. And they had a little over 1,200 kids. And one of the things they did, besides later collecting data from parents and teachers, they also called regularly initially and then annually thereafter and asked, among other things, whether there have been any medical visits, any injuries or diseases or illnesses. And if there had, they had the permission then to go in and verify them from the doctor's office or the emergency department or the hospital. And a graduate student came along a bit later and realized these records also included records of being treated for traumatic brain happened to them over time, and actually the cohort is now 35 years old. This is the work of Audrey McKinley. So what she found when she went in and looked at the records is that she had three groups she could really compare. She had a group of kids who had no medically documented, at least, traumatic brain injuries. She had a group that had had mild traumatic brain injuries and that did not require hospitalization. And then she had another group that she could compare to the first two, where they had had a mild traumatic brain injury, but they had had a hospitalization. It was always brief, 1 or 2 days. There were a couple kids who had had more severe injuries, but that group was so small she really couldn't use them in comparison. So she had these three: no injury, mild TBI without hospitalization, and mild TBI with hospitalization. So then when they looked at data down the road about what was happening to these kids, even sees the other thing she found, and I don't have not showing these data here, is that the involvement with the law, likelihood of arrest, was associated on a kind of a dose response or monotonic relationship with the extent of mild TBI that had been experienced. So just to recap, we're seeing three different kind of interacting issues that make traumatic brain injury different. The commonality is probably the damage to the frontal lobes and the specific kind of damage to the frontal lobes. And it might be that in a few years doing this presentation, we'll be able to talk about one issue that underlies all of three of these. So wrapping up, this is what I hope to have accomplished today. I think I've at least touched on all these issues, if not addressed them a bit more. And I do have some resources. NASHIA.org has some great resources. Our Ohio Valley Center here at Ohio State, we have some additional resources that may be of interest. And then I think the brainline.org website is a great source of lots of information about traumatic brain injury. So I will stop there at the top of the hour and turn it back to Carrie.
Right. Thank you so much, Dr. Corrigan. That was a very, very clear wonderful presentation on an introduction to traumatic brain injury. And we really appreciate you being on the webinar with us today. And as I mentioned earlier, Susan Vaughn, Director of Public Policy for NASHIA, was to have presented our next section on state and federal policies and programs. However, she's not able to join us today due to a family emergency. So I will do my best to present some information on her slides. And if there are questions at the end of our webinar today that I'm not able to answer about state and federal policies and programs, we'll forward those to Susan and have her answer them. So I'll give you just a brief overview of these policies and programs. As Dr. Corrigan has discussed in his presentation, individuals who experience TBI and their families may experience many needs that persist long after hospitalization and rehabilitation. And these needs go all the way from community reintegration to job training and employment and other short and long-term intermittent kinds of needs along the way. They come and go and change over time. The evolution of public services for individuals with TBI began in the 1980s, and like so many times in the past, families have played a primary role in ensuring that education, assistance, and services are available to individuals with disabilities, including traumatic brain injury. Next slide. Families have encountered all kinds of barriers and problems with eligibility requirements of different state agencies that address similar needs of individuals with other types of disabilities. They've received inadequate services in many instances where their family members may have met eligibility requirements, but they were served by staff who were inexperienced and uneducated regarding the cognitive and behavioral issues affecting TBI. Next slide. While all states face similar challenges in establishing and maintaining services, states have approached the solutions in many different ways. In general, state policymakers have asked these kinds of questions. How many people within the state will need services? What kinds of services should be provided? How do they differ from services provided to people with other disabilities? What will the costs be, and how will these services be funded? Which state agencies should be responsible for administration and oversight of the services? In most states, these questions surfaced when families and professionals advocated for funding for TBI. Advisory councils, boards, and the like have been established by governors throughout, by executive orders, by legislation, or by department heads for long-term planning to improve service delivery. In the early years, these advisory bodies were generally created at the time the TBI service program was created, and in concert with that, and to provide overall guidance to the program. As a result of the Federal Health Resources and Services Administration TBI state grant program, nearly all states now have established a required advisory board. Those advisory boards are required for application for the grant. In terms of registries, to determine incidence and prevalence of TBI, several states have enacted legislation establishing either a TBI or a trauma registry. Other states use hospital discharge data or a combination of data systems for such purposes. A few states use their registry to link individuals to services. Excuse me. Another approach states have used is to modify or expand existing programs and resources to meet the needs of people with brain injury. For example, in 1985, Wisconsin expanded the definition of developmental disabilities to include TBI as a developmental disability regardless of the age of onset. Another example might be in 2007 when Nevada enacted legislation expanding the personal assistance program for persons with severe functional disabilities to include those with TBI. States have expanded existing state rehabilitation or health facilities to include services for TBI fairly successfully. In a few states, including Massachusetts and Missouri, they've created their brain injury programs from state general revenue appropriations, Both of these states use these funds to contract with community providers for a variety of services, including service coordination to assist individuals in planning for long-term and short-term goals and to secure services and supports to meet their needs. Using state funds means that a state has the flexibility to define services, program eligibility, and provider qualifications. Over the years, other states have appropriated state funding for specific programs. For example, last year, the Alaska legislature appropriated general revenue to establish a care coordination program for non-Medicaid eligible Alaskans with TBI. States use general revenue to match other federal programs such as Medicaid and vocational rehabilitation, and for state match for federal grants. Finally, Medicaid is a program that's jointly funded. It's a jointly funded healthcare program between the federal and state governments to provide medical assistance to children, individuals who are blind, aged, or disabled, and people who are eligible to receive federally assisted income maintenance payments. Within broad federal guidelines, each state establishes a state plan which details eligibility requirements such as type, amount, duration, and scope of services, payment rates, quality assurance, and program administration. Section 1915C of the Social Security Act allows states to provide an array of home and community-based services, in addition to state plan services to targeted populations or targeted areas of the state. This option, authorized in 1981, waives the requirements that Medicaid benefits have to be available statewide and available to all who need services, and also waives the community income resource rules to allow more individuals to be Medicaid eligible. However, the waiver has to be cost neutral, meaning that if individuals didn't have community services, they would require more expensive institutional services. Waiver services may include transportation, day treatment, therapies, neurobehavioral services, cognitive rehabilitation, assistive technology, independent life skills training, specialized medical equipment, and even environmental modifications. For trust funds, most advocates and legislators have looked for sources other than general revenue to fund TBI programs. Almost half of the states have passed legislation to assess fees, fines, or surcharges to traffic-related offenses, which is then dedicated to funding TBI programs and services. Next slide. The map you see here shows states with TBI waivers, trust funds, and TBI waivers that have been merged with larger waiver programs. Many states also have state general revenue appropriated for specific purposes. This map changes very frequently, particularly with regard to Medicaid. And if you're interested, this map is kept updated at the NASHIA website. Next slide. Here are just a few of the federal initiatives that affect individuals with TBI that have occurred over the years. Valuable research is done through the National Institute on Disability, Independent Living, and Rehabilitation Research, the TBI Model Systems, and the National Institutes of Health. The CDC added prevention to its name and created the National Center for Injury Prevention and Control as a result of the groundbreaking 1995 publication entitled Injury in America, a Continuing Health Problem. In 1990, the reauthorization of the Individuals with Disabilities Education Act included TBI as a disability condition eligible for special education and related services. And in the early 1990s, due to the Gulf War, the Defense and Veterans Brain Injury Center was created. The TBI Act of 1996 authorizes funding to the U.S. Department of Health and Human Services to administer a state grant program to expand access to rehabilitation and other services for individuals with TBI. And finally, most recently, the President's Brain Initiative brings together several public and private partners to further our understanding of how the brain works in order to better treat brain injuries, disorders, and conditions. Next slide. I think Maria indicated we have a couple questions that have come in for Dr. Corrigan and myself. Maria, do you want to read those questions?
Certainly. Dr. Corrigan, the first question is, this comes from Scott Brace. I did not understand the TBI impact on the typical delayed gratification scenario. Could you please clarify the particular impact of TBI?
So what I was suggesting there is that because of some specific structures in the brain that are most vulnerable in traumatic brain injury, that the ability to delay gratification is reduced. And that's why I think we often see that there's a relatively higher incidence of some of the problems that have self-control underlying them following traumatic brain injury. So whether that's addiction or impulsivity, violence or anger, disinhibited behavior or expression of emotion, all being issues of self-control that I'm suggesting is more prevalent in TBI because of the way the brain and where the brain is hurt.
Okay, next question. When thinking about reducing adolescent risk-taking behavior, should educators consider different strategies for adolescents who have experienced TBI?
Well, that's a great question. I don't know that I have the answer, but more and more, when I'm working in substance abuse treatment, I'm talking about providers of ways of modifying or accommodating some of the changes with traumatic brain injury into the way they treat. And the idea that an adolescent who has had a traumatic brain injury might have a different relationship with risk-taking kind of seems like it might be a very good question. We need that answer.
Yes, we do. The similarities between TBI and non-TBI executive processing disorders is obvious. Is there any reason to believe that interventions targeting non-TBI individuals will be effective for TBI individuals?
I'm not sure if I follow that entirely, but I think that there's commonality in some of the executive functioning, and so if you have a treatment that is aimed at a certain kind of executive functioning problem, I would expect it to be useful whether you've got that executive problem from a TBI or some other acquired brain injury. Part of what I was trying to suggest that is even among the executive function problems, self-control is more prevalent in TBI. I think that if we had a perfect way of assessing and documenting the presence of executive functions, then we might not need to know how the brain got hurt, but we are not there.
Okay. Last question for you, Dr. Corrigan. You cited incidents earlier of traumatic brain injury among adult prisoners. Any idea on incidence and prevalence of figures for children and youth offenders?
The Shiroma meta-analysis did include some youthful offenders. We probably should ask Maria to answer that question, given she is working on a grant right now around juvenile justice. And I can't quote I don't think we have the data yet to make the same assessment. But if it's not up to 50% or higher, I will be surprised.
I'd say that we don't really have. It's too early for us to have any numbers here. Thank you, Dr. Corrigan. Carrie, one question for you that I see a couple of times is, will the slides be available for those that would like to have them?
Yes, most certainly. We will get the slides from today's presentations uploaded to the NASHIA website, hopefully by the end of today, but if not by the end of today, certainly by the end of this week. Maria and I will work on that right after we end the webinar today to get those posted for you. If you go to the website and find that they're not there, email us at training@nashia.org, and we'll be able to update you on where the slides or when the slides will be there. But yes, they will be posted there.
Great. One last question for you, John. I skipped. If you could just quickly respond to this. Would it be reasonable to suppose the
cigarette smoking, I would include as having self-control as a key issue.
Thank you.
All right, well, and I think we are about out of time for today. Thanks so much, everyone, for joining us today. We hope that you'll register for and join us for the next 2 webinars this month. ICD-10 codes for TBI on September 17th and fall-related TBI among older adults on September 30th. September is Falls Awareness Month, so great by joining our webinar. And please consider joining us on October 26th through the 29th. And again, thank you and have a